Good afternoon, everyone. My name is Angie Williams, and I'm a child welfare consultant with the National Resource Center for Diligent Recruitment at Adopt U.S. Kids. Before we begin this afternoon, I just want to take a moment to acknowledge the difficulties that our colleagues in Texas face today. We want to send our best thoughts, our driest thoughts, to our colleagues in the child welfare system, to the foster parents and birth families and foster children who are dealing with some very trying and unusual circumstances. And for those of us who have lived through disasters before, one thing we know is that whether you are in an affected area or not, the ripple effects are felt far and wide. So to our Texas colleagues, please know that we are thinking of you and sending our best thoughts your way. In July, the NRCDR offered a virtual panel discussion on using interjurisdictional placements effectively to achieve safety, permanency, and well-being for children and youth in care, which some of you may have participated in. NRCDR is pleased to welcome you to today's webinar, Building Bridges Across State Lines, the Interstate Compact on Adoption and Medical Assistance, commonly known as ICAMA, which this webinar will explore ICAMA's role in facilitating states to provide adoption assistance services, specifically Medicaid, in interstate cases. We are very excited to welcome our presenter today, Sharon McCartney, an attorney, Medicaid and child welfare consultant with the Association of Administrators for the Interstate Compact on Adoption and Medical Assistance. She's been with the association since 2002, serving first as an analyst and then as a program manager and now consultant. Sharon works to increase state understanding of federal Medicaid and child welfare law to improve state practice and child outcomes. She has been an attorney and child advocate for more than 20 years, working to improve system outcomes for youth in and adopted from foster care. Sharon specializes in interstate and interagency coordination and accuracy and its impact on Medicaid eligibility and access. Prior to working for the Association of ICAMA Administrators, Sharon was a social service specialist for DeKalb County Department of Social Services in Georgia. For that, if you can take us to the next slide, I'd like to share some housekeeping tips with everyone before we actually get started with our content. Please be aware that the webinar is 90 minutes long. That includes time at the end for questions and discussion. We will record this webinar and make it available on the NRCDR website. We will be glad to email that link to you following the webinar. Your lines will be muted during the presentation, but we want the webinar to be interactive. You can ask questions by using the chat function and respond to questions through our polls. You can also use the chat function to let us know if you are having technical issues and to communicate with NRCDR staff. As always, we want your feedback. There will be an evaluation at the end of the webinar, so please do hang around to the end so that you can share your thoughts with us. For those of you who have done webinars, Ready Talk webinars before, it looks a little different today. If you'll forward the slide, next slide please. You will find the chat function in the lower left-hand corner. Although your phone lines are muted, we have this way for you to raise your hand or submit questions, comments through the chat function. As you see in the screenshot, you can see the raise hand feature in the lower corner to let us know if you need assistance. Again, you can use the chat feature and the raise hand feature to let us also know if you are having technical difficulties. Our support team will respond to you and help you get that corrected. Now, let's get started. I would like to start with a few poll questions. Our first, I think you would agree, it would be helpful for all of us, but especially for Sharon, to have a sense of who is on the call. Please take a moment to answer the question in front of you so we can have a better sense of who is on the call with us today. What is your role related to interjurisdictional placements? Please select only one answer. We'll give everyone a few seconds to respond, and then we'll tally those responses and have that for you. Wonderful. Thank you, Rubette, for showing us that. It's nice to see the ICPC and ICAMA folks on the call with us today. Thank you for being with us. We appreciate all of you for being with us today. Moving on to our last poll question. Let us know if you have engaged with your ICAMA administrator and how long it's been since you've done that.
Oh my
Thank
goodness,
you
last
for
6 months
responding.
and almost never.
Yeah, it's interesting. It's one extreme or the other. It looks like you guys either do it frequently or not at all. I'm intrigued by that. I like it a lot. So Sharon, yep. I'm glad that you took note of that as well. So I'm going to hand it off to you and we'll get started.
Wonderful. Hello, everyone. Hello. My name is Sharon McCartney. I'm here in Washington, D.C., and I'm here to listen as well as inform. This process is for you. It's to help everyone establish a greater understanding of the Interstate Compact on Adoption and Medical Assistance, what it is, how it functions, and how its resources and staff are here to help you help the children to find security and strength and permanency in an interstate situation. Just as a small piece of housekeeping that I wanted to start with, there are 2 interstate compacts. As Angie has mentioned and you saw there in the questions that were being asked, the ICPC and the AACAMA. They're easy to get confused, and I understand that the ICPC is much more prevalent because it's much more used on the front end. So children who are in an interstate situation, both of these compacts may come into play. So the ICPC is the Interstate Compact for the placement of children, and this has that supervision over children with foster care and an interstate placement. Well, the Interstate Compact on Adoption and Medical Assistance comes into play when children have an adoption assistance agreement. So once a child becomes a child with an agreement, then the ICAMA comes into play when there's an interstate concern. Interstate compacts are put together by states. They come together and make a decision that there is an interstate concern that they want to collectively collaborate and communicate on so that there is a better understanding of how to have a uniform process to get things done, because we all know that things get complex when they cross state lines. So just a quick note, there's the ICPC and then there's the ICAMA. So today we are focusing on the ICAMA. So our first slide is why ICAMA? Well, ICAMA is there because families are created interstate, right? And families also move. And interstate permanency can be a challenge, but it doesn't have to be a barrier. We need to use all the resources that are out there and make sure that any family that's potentially available to this child and the family that best suits the child is found, regardless of whether or not that child is across state lines. The Interstate Compact and the Association of Administrators of the Interstate Compact on Adoption and Medical Assistance, they're an organization respectively, and they're created by states. They come together. They're looking to ensure interstate permanency. So securing a placement is one thing, right, everyone? But ensuring that placement is another, and we are here to help strengthen it. So finding those families, identifying those families, placing those children, and then making sure that those families receive the services necessary to preserve and strengthen that placement through to adoption and after adoption. ICAMA is that part of post-adoption servicing that helps keep that placement and that adoption and finalization strong. Okay. I have an issue. This is telling me, Rubette, it's telling me to open conference controls again. Hello? Hi.
No, I'm here. Are you not able to see the slides?
I'm not. It booted me out. I'm so sorry, everyone. Thank you for our conferencing service. You may safely close this window. To continue, follow steps below. I apologize, everyone. Let me connect you back in here. I don't know why it booted me out. What is it I need to do?
Sorry, I'm not sure.
That's okay.
I would, just reconnect, and it should bring you right back in.
Okay.
I don't show you being disconnected on my side, so
Oh, it popped back up.
Tell that.
It popped back up. I'm good.
Okay.
We're good.
Yay.
Okay, good. Here I am. Yay. Wonderful. Okay. So we're ready for the next slide? Okay. What is an interstate compact? Well, I gave a little piece, everyone, about why interstate compacts are created. They're created because states have a need. They are actually initiated by states. This is not a federal entity. It is a state collaborative approach. States took the initiative and got together. They created a contract whereby each of the states who wish to participate signed on to this contract. It's a contractual agreement between two or more states that binds them to the compact provisions. It is a contract. So if you and I contract for services and you pay for something and I agree to provide something and we sign a contract, each of us are responsible for the provisions in that contract, and we're obligated to follow the conditions and the provisions of the contract. It's the same thing for an interstate compact. For every state that signs on to be a member, they are obligated to follow the conditions of the compact that may be very different than their own procedures or protocol, and everyone has come together and agreed to do that so that we create uniformity, so that all 51 of us, right, there's all 51 jurisdictions, all 50 states in the District of Columbia. That's a lot to work with across state lines. So they said, you know what, let's write down how we feel it would best work across state lines for children, and everyone agreed to it. So these conditions are under which the states have signed on, and they say, yes, I wish to be a member. They've passed laws to become a state member, and they have reflected the ICAMA, the Interstate Compact, and its provisions in their own state laws, and it will supersede, meaning that the ICAMA itself will be followed, will come above, will trump any conflicting state laws. It will supersede those state laws. And we do this, right, so that we have consistency, conformity, and we don't have 51 different flavors of how we're going to get this done. Because we tried that, and it didn't work. It wasn't effective for children, and there were tremendous delays. Well, that's why the compacts are here, to help facilitate conformity, uniformity, and agreement across states and decide how we will best serve children in an interstate placement. Okay, on to the next slide. Okay, the Interstate Compact on Adoption and Medical Assistance. It is a legal framework because we've all signed on. We're legally obligated. And it's the administrative framework, right? Because administratively we have to decide not just what has to get done, but how we're going to do it, how we agree across all 51 groups to do this together. And we're going to meet the mandate that came out in 1980 through federal law under the Adoption Assistance and Child Welfare Act. So AA-eligible children in 49 states, and let me explain that, have all come on to here. New York is an associate member, and Wyoming is the only non-member. But everyone has agreed to abide by the ICAMA processes, and everyone uses ICAMA forms. Wyoming only meets every couple of years, and they've had a really hard time getting this legislation in their state legislature and getting it passed. But they are incredibly helpful and incredibly accommodating. They are on board, use all processes. New York is an associate member, and again, they haven't fully gone through their legislative process and put it through their state legislature. However, they are an associate member and agree to abide by all rules and aspects and protocol of the ICAMA. So what you all need to walk away with today, just know everyone's on board. The bottom line to this form right here, this slide, is everyone is on board. Okay, so next slide. Okay. We are with ICAMA applies when, and I touched on this when I was distinguishing the ICAMA from the Interstate Compact on the placement of children. ICAMA kicks in when there's an adoption assistance agreement or a foreign guardianship agreement in effect. So either adoption assistance, whether that's Title IV-E or non-Title IV-E, which some people call state-funded, or a 4E guardianship under the Guardianship and Assistance Program, again, 4E. One of the following is true. This is when the ICAMA is going to oversee a case. A child moves with the family to another state while the agreement is in effect. A child is initially placed for permanency with a family in another state. So two circumstances that are interstate, right? When a child is being placed in an initial placement across state lines prior to finalization in this pre-adoptive phase, and you've got state oversight, or after finalization and a child moves with their family to another state. So those are the two conditions. Both of them are interstate, and you need to have an adoption assistance agreement signed. Now, just as an aside, some states sign adoption assistance agreements prior to finalization while the child is still in state oversight and in a pre-adoptive phase. That child is still in foster care technically, but considered a child under adoption assistance, and they are covered under an adoption assistance agreement. In fact, most states begin adoption assistance for children who are eligible prior to finalization. So that is the much more common situation where a child, if they're placed interstate during this pre-adoptive phase, they will have adoption assistance. That's much more common. So you'll see that. You'll see that. And there's times in which the ICPC and the ICAMA are both at work for the child and for the benefit of the child. Okay, on to the next phase. Next slide. ICAMA's main goal, everyone, is to facilitate Medicaid for children with an active adoption assistance or 4E GAP agreement and in interstate cases. A quick piece of Medicaid law. Medicaid is administered according to the state in which you live, your state of residence. And so what used to happen is that children were receiving Medicaid from the state that supported the adoption assistance agreement, but then that case was closed whenever the family moved. And as our nation becomes more and more mobile, that became more and more of a problem. Families were left to reinitiate cases, go back and look to open cases in new states, and have to contact Medicaid departments. We decided to keep it within child welfare and ICAMA staff, and families need not, in a perfect world, have to touch on that Medicaid opening in the new state. That is completely on the Interstate Compact on Adoption and Medical Assistance. ICAMA staff does that. ICAMA forms achieve that. ICAMA databases preserve that. That is what we are here to do, to make it as seamless as possible for children who are designated as special needs children to receive the Medicaid that is so vital, right, to their health and their well-being and the continuation and strength of their placement. Okay, on to the next slide. Okay, under the Compact, use of uniform ICAMA forms and procedures is an obligation. It's not that states have come on and decided to kindly work together. That's true. That's true in part. It's also that it's state law. So states who are members, and like I said, that's next to everybody besides New York and Wyoming, have it in their own state law that they will abide by the Interstate Compact and they will use its procedures and protocol in lieu of their own so that uniformity and consistency is achieved. So states are obligated lawfully under their own state laws to enact the ICAMA and abide by its forms and procedures, and all of us working together in hopes that the transfer of children across state lines and the benefits that they come with are as seamless as possible so that no child is ever lost between the cracks and no Medicaid is ever accidentally closed or no service is received. This is what we're here to do, to make it as strong and smooth a transition as possible. Okay, so our next slide. Okay, the ICAMA connects states. It ensures proper documentation. So our forms, right, let you know that a child is either 4E eligible or non-4E eligible, which correlates to their Medicaid eligibility across state lines and other services that are included in the adoption assistance agreement. So you've got proper documentation that we all agree what we will use to refer to confirm eligibility across state lines. They sign the ICAMA forms to certify that information is accurate and eligibility meets federal requirements. So the assistant state does this, right? So the assistant state is a state that has the agreement with the child. They use the ICAMA forms and notify the state in which the child is going to be a resident that this child indeed is adoption assistance eligible, and the child, through whatever category of assistance they are eligible, are also therefore Medicaid eligible, and then they will trigger that new state across state lines to open a Medicaid case for this child. And all of this, again, is done behind the scenes, quietly, efficiently, and together. We communicate, we collaborate, and we coordinate so that families are not interrupted in their lives and the support of these children. Okay, next slide. Okay, ICAMA forms. Woohoo! Forms. I know they're not the most fun, but I will cover them, and you can get a good glimpse on the inside of looking at these forms, how they were written, why they were written, and how terrific they are in achieving the job that we're trying to achieve, which is behind-the-scenes, seamless notification state to state of information necessary to open a Medicaid case. So this is ICAMA forms. Here we go. Next slide. So the ICAMA 700 form. 2 years ago, ICAMA launched the new form series and a secure database. So people are much more familiar with the NICE. ICAMA has its own version and a database that we have purchased and worked with outside organizations, data groups to create, to fill with data, and to use across state lines. States use this e-format to exchange information safe, quick, and effectively with absolute security. These are high-level security systems to protect this very sensitive HIPAA-related medical information for families and children. And there's a link right there to go to the online user guide to explain further. But the quick down and dirty is that is the ICAMA 700 form series. We redid them. We have a new database, and they are there and working strong and getting stronger each day with greater and greater state participation. Okay, next slide. Okay, the next form is the 7.5. The purpose of the form is to communicate between the agreement state and the state in which the child is living, right, where that family has moved or where that child has been placed, and changes to the cases open before the ICAMA 700 database was launched, okay? So we have to have an alternative way to catch this data, because to go back and to have entered all of these cases would have been an enormous undertaking, and there was not the staff people power to be able to do that. So we've got this. The ICAMA 7.5B is information designed for state adoption professionals. So you've got the 7.5 and the 7.5B. Okay. Oh, I've got a quick question here. The assistant state is the sending state or the receiving state? I bet, this is Heather. That's very often the language that's used within ICPC. The assistant state is, in the minds of most people, the sending state, but it may not necessarily be, right? Because you've got the assistant state, say the assistant state is state A, and then the family moves to state B, and then now they're living in state C. So you might think of state B as the quote-unquote sending state because that child just moved from B to C. However, the assistant state is the state that we're looking toward. They are going to be and are ultimately always responsible for communicating with any other state that this child moves to for a permanent move or goes into for a specialized school that they are living in or in a residential treatment facility. Those are all circumstances that may also happen, that this child moves to another state, okay? But it may not be where the family also moves. It may be that the child is living in a dormitory and in a specialized school or in a hospital in which they are in treatment patients. So that's a possibility. Think of it this way. There is the assistance state, which is the state with which the child has the adoption assistance agreement. They're the ones who signed on and pay the support monthly. The AA maintenance payment made by the assistance state. That is the state that we are always going to talk about. So it's either the assistance state or the state in which the child is living, which is the resident state. You might want to consider it the receiving state if that's where, the ICPC language in your mind takes you. But for ICAMA purposes, it is the assistant state and the resident state. The assistant state will always be the one that translates this information, because even though state B might be in the middle there, state B is going to go back and tell the assistant state, hey, this child is moving. And they'll go, oh, okay, I'm going to go kick into the ICAMA process. I'm the assistant state. I will process that. The referral will come from me. I hope that helps. Let me know. Does the state pay a fee for use for this database? Nope. Every state has an assessment fee that's a basic flat fee across the board, and states pay that into ICAMA for its support, and it's rolled into that. We have subsumed an enormous amount of the cost to this, and currently we do not have an additional fee that comes from it. And we're very proud of it. It's difficult because we have a very small budget, but it is in fact true that we do not have an outside fee that is solely dedicated to the database. It is the flat fee that we have across the board for an annual assessment for each state, which right now is $5,000. And PS, 50% of it is reimbursable federally under your operating costs under Title 4E. So it costs you $2,500 out-of-state dollars. We are a wonderful bargain. Okay, on to the next slide. Okay, the 7.02. It's a cover letter to parents. We came up with this, you guys, several years ago. We decided that it would be a great idea to have a piece of information, an informational white sheet that went out to the families to give them a heads up about the things that they might encounter as an interstate family. So to give them a heads up on how to work with interstate obstacles, to notify them that they must notify the assistant state of the move, that if they are going to move and the child has any medications that they take, it's a good idea to do an extra fill of medications, get your prescriptions in order before you move, because the child never loses eligibility for the Medicaid, and it should be seamless, but sometimes there's bumps in the road, and you're waiting to get that Medicaid conferred in your new state. They should always be able to get a Medicaid case opened. Sometimes there may be a delay. There shouldn't be, but we know that sometimes this happens. So there was a letter that we designed for parents and guardians to inform them, okay, that an ICAMA 700 was sent to the resident state. It's not an interstate form. It's designed so states can effectively work with the families with whom they have an agreement. So this is a form for the families. And the families also receive a 700 for their records. It informs them that an ICAMA 700 was sent to the resident state. It's just letting them know what's going on with the case for their families. Okay. Next slide. The 702A provides helpful information and tips for parents adopting or moving interstate. This is what I was talking about. I'm sorry, I conflated my two forms. It's 702A. So that was the 702, and that was just a notification form to the families. Let me clarify and correct myself. 702A is the one I conflated. This is a separate form. It's really a nice informational sheet for the tips for the parents, giving them some heads up on how to best move interstate. And here are the examples. It notifies adoption worker as soon as a move is planned, because we know that our families will oftentimes not do that. They will, after the fact, after a move, say, how come my Medicaid didn't magically reappear in this next state? Because there is not always a full understanding given to the families of how Medicaid works. So they'll move and expect Medicaid to follow with them, and it doesn't. And it doesn't work that way. So we let them know, hey, notify your adoption assistance worker as soon as your move is planned. Do it in advance. Set this stuff up as far in advance as possible so you can help them help you have a smooth transition to that new state. It provides a copy of the adoption for your guardianship agreement, whichever it happens to be. Either it's an adoption assistance agreement, either 4E or non-4E, or that Title 4E guardianship agreement. We don't assist in transfers of state-funded guardianship. Just a small side note, because there is not a guarantee of Medicaid to those children. There is within non-4E and 4E adoption assistance. There's federal law and child welfare law that guarantees Medicaid to these children. There is also the guarantee, as there is for any 4E recipient, for guardianship. So those groups, those three groups, Title 4E AA, non-4E AA, and 4E guardianship, they all have Medicaid provisions in federal law, all of them. So we subsumed guardianship and help those families and those states with those agreements. We help those cross state lines and work with the Medicaid and do the same process and help them along all of these steps. However, children who have state-funded adoption assistance and state-funded guardianship assistance are different. They are just different. There is not federal law for children who have state-funded guardianship. There is no correlation to Medicaid guaranteed for that group. So we do not have that group subsumed into the compact. The compact does not cover that group. I just wanted to put out a little FYI there. And that's the reason. It's not that we're not looking to assist those children. It's that they're not guaranteed Medicaid under federal law. Okay. The 702A provides information on how to secure emergency medical care, okay? Because if you are Medicaid eligible, there's a wonderful, wonderful federal regulation that says that state administrative efforts, state administrative procedures cannot interfere with the receipt of Medicaid to an otherwise Medicaid eligible individual, including our kids, and that the state must provide Medicaid 24/7. It's really rare in federal law to see something so beautifully, simply, and strongly written. There is a directive in federal law that says, state, if you have in your residence an individual that is Medicaid eligible, you will provide Medicaid 24/7. So these children do not have to reapply for Medicaid. They do not. They remain Medicaid eligible across state lines. So though the case is closing Medicaid in the previous state in which they lived and opening in the new state in which they live, that Medicaid eligibility never closed, never lost it, never did, never did. Only the case was closed and a new case opened. And all of this is only because Medicaid is provided through your state of residence. We do not have a uniform federal system of Medicaid provision. We do not. We do not have a universal federal health care under Medicaid. It is all state-specific and state-administered. So the case must close in the previous state, open in the new state. And just please, from this slide, remember that children never lose their Medicaid eligibility. Cases opening and closing is not an indication of their eligibility status changing, only a state administrative need, not a reflection of the child's eligibility. They remain eligible, and the state must and will provide Medicaid 24/7. Explains that Medicaid services are different in each state. They just are. There are mandatory services in the state that are mandated by federal law, and all states must provide in the same scope and duration and extent within the state. And then there are optional services, and states have the option whether or not to choose from that list of services. And as an FYI, and I have a Medicaid training that I can go deep into, anyone who is interested. We also do that at the ICAMA conferences, and I also do them in webinar if you would like to have a deeper understanding of Medicaid. A quick down and dirty is the fact that on that optional list, everybody, are the big ticket items. And I mean big ticket items. I mean mental health is on there, inpatient treatment, psychiatric is on there, glasses is on there, behavioral therapy is on there, speech therapy, all the therapies and support services that we think of for our children in need that come from state care that so often are overrepresented in these needs for special services. All of them are optional. All of them are optional. So a state can choose to have them, and if they do choose to have them, then they can choose how they provide them, and that will differ across state lines. You will have a very different provision of mental health services in one state versus another state. So families need to be aware of that. They also need to know that there's also federal law that will help equalize the services that you receive across state lines, and you can request to get a service that a state does not provide in their state plan. You can request it and get it approved, and there's ways to do that. Just heads up to the families, this may be a case circumstance, and here's how you help. And how you can help, too, is call ICAMA, and we can help you to understand that and give that information to the families and tell them how to go about getting a specific service that may be denied. Okay. It also lists the ICAMA website for additional information. And at the end of this presentation, we'll also have my name and my number to reach me for any additional questions that you have, specifically dealing with Medicaid. I call myself a reluctant Medicaid expert. I thought I was signing on to do child welfare, which I had done in the past, and then found myself confronted with Medicaid issues more often than not. It probably takes up 90% of the work I do most days because of the difficulty with Medicaid and in understanding how it works within state and particularly how it works across state lines. So consider me your reluctant Medicaid expert, and I'm here for you. Okay, next slide. Okay, the ICAMA is a document. To bring the ICAMA to life, ICAMA created the AAICAMA. Now, the AA stands for the Association of Administrators of those who administer what? The ICAMA, the compact itself. Just like ICPC has an AAICPC, which is the Association of Administrators, the group of people, the AA just means a group of people, okay? They implement the ICAMA. We work together. They are designated. It is a fast, reliable format for communications. It's got the database, technical assistance, resources, and training. That's me. I do the legal assistance. I do the technical training, the technical assistance answers. If you've got a question, it's very specific. I can answer you more often than not. I've created a resource written out that describes the federal law, how it applies, and what you need to do to apply it for the benefit of a child. More often than not, there's nothing new under the sun. There's similar questions to the same theme, and we're here to help answer those for you. Information and guidance on permanency, we do those as well. Child welfare, 4E. National meetings and connections to federal, state, and nonprofit permanency stakeholders. I'm pretty sure I have the Centers for Medicare and Medicaid Services in Baltimore on speed dial. I talk with them very frequently. They come, they present at our conferences, they're well aware of our population and how special our populations are and that they may need us. They're there, and I call them. Also, the Children's Bureau. So we have that relationship with them as well. We have been part of the NRC in the past. We have been under an Adoption Opportunities Grant in the past. And so we are very familiar with the CB and very familiar with CMS, the Centers for Medicare and Medicaid Services. ICAMA is a cross-section of adoption and medical assistance expertise. As I just mentioned before, I had thought that I had started this over 15 years ago and that the focus would be child welfare. That's where I got my start before I went to law school, was in social services in Atlanta. And I loved it. I really loved it, and I wanted to work more with the legislation and policy and help scope these things on a broader-based level as opposed to case-specific, becoming much more policy-specific. And then found myself doing a lot of medical work because Medicaid is not the easiest thing. If you're confused by Medicaid, you're not alone. Take heart. I am confused by Medicaid on a daily basis. It's a tough go, and I'm here to help. Okay, next slide. The heart of the ICAMA process is a child. It's a child with special needs, right, or else they would not have been eligible for adoption assistance in the first instance. So these are our kids. These are kids with special needs, and boy, Medicaid is really necessary. And consistent Medicaid is really necessary. And fighting for specific services that may have been initially denied by a state is really necessary. And understanding the fair hearing process and the fact that there's no reason to ever accept no as an answer is really necessary. I've said and started to say more often that we all have our hats, right? I'm an attorney. I'm also a child welfare expert. I work with you all, so I'm also a state liaison or a federal liaison. So I wear different hats, but I've started to say that the lining to every hat that we all wear is advocacy. It lines and underlines and girds everything we do because it's not always an easy day. It's not always a yes. If it were, my goodness, we wouldn't all need to work as hard as we do. And we do. And we work together. So the answer may be no initially, but we can almost always work together to get to yes. And so at the end of the day, we all remember that it's a child with special needs that we're working toward. And I have a great day if at the end of the day I secure Medicaid or a specific service under Medicaid for a child that had been previously going without, or an entire group of kids that a state has incorrectly assessed and is going without due to an error. So together we can do this. It's all about the kids. Next slide. Questions and answers. So that is
Sharon.
Uh-huh.
Sharon, hi, sorry
Yeah.
to interrupt. If you, in the lower left-hand corner of your screen, if you can click on the questions tab, I've been channeling the questions into that one tab so that you can have them in one place.
Perfect. Okay, I've got 7 questions that are listed here, and I hope I'm pronouncing people's names. Help me out if I'm not. Janelle, why are some states allowed to not cover other states' children who were covered in the sending state? I got to know what you mean by covered. Do you mean Medicaid covered? If you mean Medicaid covered, then you can only mean children who are receiving non-Title IV adoption assistance. So let me unpack this question. Why are some states allowed to, okay, can you get that question back? Someone just took off that question.
Yeah.
There it is. Thank you. Why are some thank you so much. Why are some states allowed to not cover the other state children who are covered in the sending state? Okay, so let's give an instance. I like doing scenarios. So here's a scenario. A child is in care. They're in out-of-home care. They're in the custody of State A. And then they move from State A, where they were receiving, and the only way this can happen is for it to be a non-Title IV child. Let me be beyond clear today. No child or young adult who is receiving Title IV assistance, whether it be adoption assistance, foster care, or guardianship assistance under 4E shall ever be denied Medicaid. Say it with me. No 4E kid ever goes without Medicaid. Ever. Ever, ever, ever. If they do, it is wrong, and you fight to correct the inaccuracy. Okay? Some states provide adoption assistance to 18. Some provide it to 21. ICAMA has been fighting for years and years and years and working with CMS to correct this systemic problem whereby some young adults who are 20 go into a state that close out their own 4E AA at, say, 18, and they won't provide Medicaid. They say, oh, well, you've got an adoption assistance agreement that's active and valid and a signed agreement, but I'm not going to give you Medicaid because we close ours out at 18. And that's what I call a sequence problem. The sequence is this. You, State B, who are denying this 4E kid who's actually 20, so a young adult, Medicaid, that's not your choice. The choice to extend adoption assistance to 21, that right and that determination and that decision is with the assistance state from which that child was adopted. Okay? That child, young adult, is permitted, based on the assistance state's determination, to receive adoption assistance at least to 21. That's the federal end point. So they are 20 and they move over to State B. And State B says, nope, I'm not going to give you Medicaid. It's wrong. You say, you don't make that determination. I make the determination for 4E. Now let's go to Medicaid law. And Medicaid law says any 4E recipient is mandatory eligible for Medicaid. It doesn't say anything about whether or not your 4E plan agrees with the other state's 4E plan. That's absolutely not the point. The point is federal Medicaid law mandates that all 4E recipients receive Medicaid. So I got to unpack her question and break it down. If it's a 4E child, it's wrong. It's inaccurate. You let them know. You supply them with the law. If you don't know where the law is, you call me, and I will give you a resource. And that resource is an explanation. That resource addresses the specific issue where there are some states that have been not providing Medicaid to children who are 4E eligible. So the simple sentence needs to be, any 4E eligible individual under the age of 21 is eligible for Medicaid anywhere in the United States of America, period. Period. It's that simple. So that may be a denial that you're receiving, and you say, how do they get to do this? The question is, how can they do this? The answer is they can't, and it's wrong, and it happens. So that's one instance. A second instance may be if the child is non-Title IV-E, and that gets stickier. So if a child is non-Title IV-E adoption assistance eligible, most states will willingly, happily provide that child Medicaid, and a case will open. However, there's a tiny sliver of states that do not do that. We've worked with those states. We've tried to bring around those states. I have an entire law review article that I wrote and published in Illinois in their law review journal through one of the universities that addressed this very specific issue that I don't feel that federal law supports that practice. Well, I can feel that all day long, but the bottom line is there's 4 states that continue to deny children who have non-Title IV adoption assistance Medicaid in their state. And that is that these are the states of Hawaii, Illinois, New Mexico, and Nevada. Those 4 states across the board will deny children who enter their state supported by a non-Title IV-E adoption assistance agreement from another state, Medicaid. My answer to you is, how are they able to do that? As I just said, I don't feel that's how federal law is meant to work. I'm happy to share with you the law review article. But we continue as ICAMA to work with the states and hope to change their minds. We've done it. We have changed states' minds. There have been other states that had that practice, that we have undone that practice, and they've changed their practice across the entire state and adopted the practice of providing Medicaid to children who enter their state. We've done that. We have, with our tiny organization, worked and looked to work with the legislation in those states, the legislative bodies, through their child welfare departments, to change it for the benefit and the betterment of children. We do that. But right now, you may get the answer of no to Medicaid in Hawaii, Illinois, New Mexico, or Nevada if your child that you're supporting places into one of those states. So that is a possibility. And I hope that fully answered the question for you, Janelle. Janelle, ask a further clarification if that did not fully answer. Your question was, why are some states allowed? My first part of the answer was they're not allowed for 4E. My second part of the answer, for non-4E, I still don't think they're allowed, but the practice still stands, and we have to work with it and around it. I hope that answers your question. Okay, so I'm going to go up to the top. Can the 7.5 be electronic similar to the 7.0? Yes. Who initiates the 7.02? That's going to be coming from the, that's going to be the assistant state. Next question. Is there a listing of what states will provide Medicaid? Is there a listing of what states will provide Medicaid for non-4E cases? Yes, absolutely. There is, absolutely. And I have that list. We have, it's called reciprocity, COBRA reciprocity, because there was a legislative COBRA that came through the federal legislation in 1985, and it's referred to as COBRA reciprocity, and I do have that list. So if anybody wants a resource from me, at the end of this presentation there will be my name, my phone number, and my email. Please email me any requests for resources. I am more than happy to shoot those to you. And the answer to that question is yes, we absolutely have that list. We have the list of who will provide and how they will provide. Megan, are some states permitted to keep Medicaid open even when a child leaves and moves to a new state? That's a great question, Megan Tarantino. It's a great question, and I get this question, and I posed this question to the feds over at the Centers for Medicare and Medicaid Services, and they thought it was a crazy question. They thought, well, why would anyone want to keep 2 cases open? And it was clear that they worked up in what I call the 60,000-foot level or the 30,000-foot level and not on the ground. When you work on the ground, you really understand that this family is moving, and it hasn't, the move has not completed itself, and all things haven't been set up. So it may be a small move across state lines, and maybe they may still be using providers in your state. That happens here in D.C. all the time. We have such a triangle of commerce and life in D.C. between D.C., Northern Virginia, and Southern Maryland. We just live in this triangle. I go to both Maryland and Virginia constantly. I've got doctors, I've got family, I've got shopping. I go to Costco right across the state line 2 minutes away on the Virginia side. So it can very well be that a family wants to continue to use a provider that's in your state, that they are physically over the border in another state. So I said to them, hey, federal government, for the betterment of families and the strengthening of this permanency and to keep this placement stable, can we have these open? And they were aghast. They said, no. You can only have one active, valid Medicaid case open and one card that you're using. And they said, this is to prevent fraud. I said, well, I can understand that. And I said, but what if there's no duplication? What if there's no duplicative effort of a single service billed to both one state and another state? Two states aren't going to bill for the same service. We're just keeping them open until the dust settles. And they said, well, why would two states want to do that? And I said, because that's how interstate life works, and that's the reality for these families. And that the bottom line is that I can say formally the federal government does not endorse keeping open multiple cases of Medicaid for a single recipient, meaning our children, right? But I can also say that no, I do not see the federal government coming and auditing and this being a problem. The only thing they're going to audit is if there's fraud, if there's multiple sources billing for the same service. That's fraud, right? Or billing for a service that wasn't received. But if it's not fraudulent, if it's for the betterment of a child, if it's so that you can continue to have the family receive services until the dust settles across state lines, I'm going to tell you, read into my words and do what is in the best interest of the child, and that I do not see the federal government coming in and doing an audit. The formal answer is they do not condone, endorse, or promote multiple cases for a single recipient. But they have heard us and heard us loud and clear that it takes time for a case to close in Medicaid in one state and for the dust to settle and all things to open and transfer in another. So I will nod and wink and let you hear me in between the lines as to how to operate with that. Here, what, if anything, is different for a youth over the age of 18 years old who moves from one state to another under an adoption or four-year? Absolutely nothing. Deborah Smith, here's your question. What, if anything, is different for a youth over the age of 18 years old who moves from one state to another under an adoption or 4E guardianship agreement? The beautiful answer to that, Deborah Smith, based on the ICAMA, is that the answer is nothing. Absolutely not a thing. Okay, Crystal Korberg, do you know if braces, orthodontics are included? Okay, Crystal, do I know if? You need to know your state. This will be state specific, and I'm going to tell you two things. One, it's state specific, okay? And I'm also going to guess that braces, orthodontics are going to, orthodontics, not ortho, okay, you mean solely dental. I saw braces and I saw orthopedics. Okay, no, you don't mean braces for the legs, you mean for your mouth. Okay, do you know if braces for the teeth and orthodontics are included? I'm going to tell you this. Dentistry is an optional service under Medicaid, period. States are permitted. It's not a mandatory service mandated by the federal government to include in your Medicaid state plan. Medicaid state plans differ across states. Medicaid state plans are the agreement between the state and the federal government as to what that state will provide in their Medicaid program. It is a contractual, legally enforceable document that reinforces that which you have in Medicaid for these families. So Medicaid is health insurance, right? So it's 51 different plans. Think of Medicaid not as a single plan, but 51 different insurance policies according to each state in which you are residing. And if you move, you got a new policy. You don't take your policy with you. That policy is going to be the policy of the state in which you are living, physically present. So your policy changes not by your choice because, right, if you've got private insurance, you get to pick. You stay in one place, but you get to pick. And if you move, your insurance moves with you, right? Because all of us, if you've got private insurance, it's portable. Medicaid is not portable. I'm going to be as clear as I can be. Medicaid is not portable, which makes it the reason that I work 90% of the difficult things I do and 90% of the work that I have on Medicaid and Medicaid-related issues for states, collected states, and across the board. So Medicaid is not portable. States do not have to mandatorily include dentistry. That includes braces and orthodontics. However, saying that, let me be very clear, and again, I do a Medicaid training that's much more specific to this. If a child has a medical need that's considered a necessity, and orthodontics can be a medical necessity. It can be. If the structure of a child's jaw is at place, if their ability to chew is at place, if their ability to retain the teeth in their head is at place, those issues are structural and can be considered necessary medically to meet. And there is a very specific Medicaid law that's called EPSDT, Early and Periodic Screening, Diagnostic, and Training, EPSDT. And in it is a beautiful, tiny provision that says any Medicaid individual under the age of 21, which means they're kids, right? It's specifically and only for kids. EPSDT is not for adults. It's only for children. And it's meant to equalize the receipt of specific benefits across state lines. They realized after Medicaid was created in 65, in the early 70s, Congress came back and fixed it. It said it's not fair that a family moves and were previously able to receive a service for a child in one state and can't receive it in the next. We're going to equalize it across states. So any medically necessary service can be petitioned to the state. And if it's deemed medically necessary, the state must provide the service. Let me be as clear as I can be. Must provide the service, even if that service is not included in their state plan. They have to do it. But you have to, when you are denied the service, you have to do an appeal, you have to do a fair hearing request, and you have to say, no, I need this, and I'm going to gather the data through the different medical sources, whether it's an MD, whether it's a PhD, whether it's whomever is on this child's medical team or this child's therapeutic team. You get that medical documentation, you bring it forward to the state, and you substantiate that need is actually a medical necessity, and you look to win, and you get that service provided. So I'm going to say there is not the answer no to almost anything you request. You can fight for it and get it determined medically necessary. And if you can get it determined medically necessary, the state must provide. So I'm going to tell you, with regard to dentistry, orthodontics, braces, the answer can be yes. It can be yes. It is not always, and I'm not going to lie to you, it's probably invariably going to be no to start with, but it can get to yes. And we can help you get to yes. Okay. How do we know what another state's medical assistance plan covers and does not cover? They have to publish this. It's available. It's available online. Every single state has their state plan with the Centers for Medicare and Medicaid Services online. So if you went to CMS online, you can see what a state is looking to provide. But again, if you don't see it there and you've been denied, there's a way to get that determination for medical necessity. There's a way to at least work to get it. It may be denied you, but you can fight for it. So Julie Hoffman, how do we know what another state has in their plan? It's published. It's published online with the Centers for Medicare and Medicaid Services. They have to be transparent. There needs to be absolute transparency because this is your plan, right? This is your insurance. How would you feel if you had private insurance and they weren't required to tell you what they cover? Well, actually, tell you the truth, that has happened to me, and I'm sure it's happened to those of us on this phone call too. They're not always transparent in private insurance either, but you can force them to become transparent and to press for services and to make themselves clear and known. And I've had to do that multiple times in my personal life. As an attorney, I know what their obligations are under the law, and I must press. And I've done that multiple times. It's the same here. You need to press the state sometimes. The transparency needs to be there. The Centers for Medicaid and Medicaid Services have those up on their line, on their online. Okay, Carissa Decker, can you speak about state-funded gap reciprocity? There isn't. It's a sad, quick answer. There isn't. And you speak about state-funded. So if you have a guardianship assistance agreement with a child, and you are a state, obviously, that has state-funded guardianship. Many, many states do not have state-funded guardianship or federally funded 4E guardianship. But for those states that do have state-funded guardianship, and that child moves to another state, that Medicaid does not follow that child. So there's not that reciprocity. That child may be eligible under another Medicaid eligibility category, and that family should be, and I've got a list of things to do and ways to help if you move to a state and you don't have a category. So Medicaid is received by category. I call them flavors. Think of Medicaid like a house, everyone, and you may enter through the door, and the door is strong and it's big, and that's 4E, and that's a great strong door, and you're going to breeze right into that house known as Medicaid. But you know what? You might have SSI. You might have to climb through the window. You'll get in, and it may be a little more difficult, and it varies across states, and there's 3 different ways that SSI works in states to get you to Medicaid, but you get through the window. But non-4E, meaning state-funded guardianship, it's a smaller window, and you might not get through the window, and you're not going to get through the window that got you in the window in the initial state. So in that new state, they do not need to or are obligated to or have a formal construct through federal law to provide Medicaid to that child, so that that child's eligibility for your state-funded gap won't get them through the window in the new state. So you got to try a different window or door and see if that child may be eligible. If the family has an income eligibility component, maybe the child's SSI eligible and nobody has pursued their SSI eligibility. Maybe there's another category under which we could try to get that child Medicaid eligible. Or, to tell you the honest truth, you look back to your guardianship assistance agreement that you have with the family, and if the language in that agreement, because those guardianship agreements as well as those AA agreements are contracts. So you as a state said to a family, will you take this child? And they said yes. And then they said to you, if I do, what will you give me? And you said, I will give you X, Y, and Z. And they have a contract for the guardianship assistance agreement, which is what that is, contractually obligates the states to the provisions in that contract. You may need to continue to provide medical assistance to that child in another state. So it doesn't mean that they won't receive. It may mean they will not receive from the state in which they're living, but they may receive it from the state from which they have assistance. If you go back and look at your agreement with that family, if it says that you will continue to provide medical support for the life of that guardianship assistance agreement, you are legally obligated to give that child medical assistance in some form or fashion in that new state. Some states will purchase private insurance plans for the child in the other states. Some states will do an agreement with the state in which they live to use the Medicaid of the assistant state and work with the resident state to do reimbursement. There's ways to do that too. It's not the easiest and cleanest way, but that obligation may well be there that's retained within the guardianship assistance agreement contractually. So you as a state may need to and are obligated, if that's what your statement is within the agreement, to provide for guardianship assistance and medical assistance in that new state. Okay, Patricia Evans.
Hi, Sharon.
Hi.
I just wanted to call attention to the time and make you aware that we have about 25 minutes left in the webinar.
Perfect. Okay, Patricia, I've got 6 left. I should absolutely be able to do this. Patricia, if a child receives a subsidy in one county, then the family moves to another county in the same state. Does the case move from county to county? I've always just taken care of my kids within my state. Please advise. County to county movement should have absolutely zero impact on any of this. Medicaid is received through the state, and it is not county-based. So an inter-county move has zero impact, and the ICAMA is not triggered at all by an inter-county move. Okay. Nancy, I'm going to pronounce it Pakovis. We have not been using the database to submit ICAMA forms in Ohio because it wasn't working properly. We've been sending this form straight to our liaison in Columbus. Is it working yet? I hope so. That's going to be my answer. I hope so. You can fingers and toes crossed. It is a fairly new database, everyone, and so there are glitches. There's bumps that we will encounter, and I don't want you to have to circumvent the bumps. I want us to work through those bumps and not have you to have to go through any additional machinations to get this thing online. Is it working yet? So send me an email as a reminder, Ohio, and I want my answer to be yes. So please know that whenever there's glitches, we always work very, very quickly and promptly to iron them out. So the answer should be yes. Okay, Michelle. What about non-furry children past 18? What about them, Michelle? If you as an assistant state, I'm not sure what state you're from, Michelle, if you as an assistant state continued Title IV adoption assistance past the age of 18, woohoo! I want everyone to do that. The federal funds are there. The ability to make your own decision is there. The law has always been if the state of assistance decides that the child has a mental or physical handicap that warrants the continuation of assistance, they may continue to 21. This is long before fostering connections came around in 2008. You don't have to abide by the conditions in fostering connections for a child to be eligible past 18. You've had, in federal law, the ability to just make that determination on your own. Hey, there's a continuing need, right? There's a continuation of assistance that appears to be necessary. I'm going to continue to 21. And when you do, that kid is 4E eligible like any other kid is 4E eligible. And they cannot be denied Medicaid in any state in the United States of America, period. And you may get a no from some states that end at 18. Call me, and we will work it through, and that Medicaid will be opened. That child cannot, under federal law, be denied Medicaid. Can you please give us these federal regulations? Absolutely. You know I've got all of this written. I've got all of this written, and I'm happy to share. And you know, the law review article I've got, the thing that's terrific about a law review article, number one, is getting it done. They're just being done writing it. But the other beautiful thing is that all of those footnotes in the article, they're a beautiful cheat sheet, everybody. They're a cheat sheet to the law. So you read the article and you're like, oh, Sharon references this law, and it's got a footnote. So let me look at number 5 at the bottom. Oh, right there. There it is. So it's a wonderful walkthrough, and I also have multiple resources through 15 years working with ICAMA created to help you guys, and training points. I have PowerPoints, many PowerPoints, and specific Medicaid training points where the training point is in the slide, and then right at the bottom is a citation. As an attorney, I never feel comfortable saying anything without, boom, citing it. And that's your strength, you guys. You say, this is the law and you must. This is a federal mandate and you must. And if you have any problems going to the other state and there are still difficulties, then you call me. And then I get on the phone. I mediate between states all the time. And then if the 3 of us can't work it out, then I talk to the feds through CMS, and then the 4 of us would work it out. So it will get worked out. At the end of the day, none of us are going to allow a 4E child to go without Medicaid because it was hard won and hard fought in Congress, and there are few enough protections for our children, and this is a protection that was mandated, and it will happen, okay? So just know that I will help it happen. I think you just got rid of one question I didn't finish with. So if you could put that one back up.
It was a statement. Yeah, it was a statement. It wasn't
okay. Okay, perfect. Question 2 left. Michelle, an AA payment is not required to extend Medicaid coverage. However, we've experienced this in another state. It's just okay. I really don't know how you're phrasing this question. An adoption assistance payment is not required to extend Medicaid. Let me be clear. You can have an adoption assistance agreement that has a 0 maintenance payment. Yes, you absolutely can. We call them Medicaid-only assistance agreements. Sometimes families demur. Sometimes they say, I don't need the money, but I do want the Medicaid. I've never understood that, but I've heard that happens. To me, I would have that assistance and put it into a bank account for the kid. And when they turn 18 and we promote going to college or going on with life, that money is theirs to have. But you're right. Sometimes there's a zero payment. It's not required, okay? You do not have to have an adoption assistance maintenance payment paid to be eligible for Medicaid. Number one, you're right about that. To extend Medicaid coverage, I'm just wondering if you mean to extend Medicaid coverage, meaning to give them Medicaid. So if that's the case, yes, you don't need an assistance payment to be able to give that family Medicaid. However, we've experienced this in other states. Is this okay? I'm sorry, Michelle, clarify what you mean by that, because I'm not understanding what you're experiencing in other states. Are you telling me that if you don't have a payment, other states are denying Medicaid? I'm going to tell you, if that's the reading to your question, they are in error. So if there's a state who says to you, I'm not going to give this child Medicaid because there's no maintenance payment being paid out, I don't know how they know that, number one. But number two, unless that's detailed in your adoption assistance agreement and that copy is sent over with the ICAMA forms and they go, oh, look, there's a zero payment, I'm not going to give Medicaid. If that's what you mean, it's inaccurate. And we will assist you to work with that state and provide Medicaid. So that should never preclude a child from receiving Medicaid if there's a zero payment. Okay. And Michelle, again, if I didn't fully answer your question, let me know and clarify within the questions up there, and I'll get back to it. Julie Hoffman, can you share with us the link to the state listings of MA benefits? Okay, yeah, shoot me an email. Julie, shoot me an email and ask me this, and I'll dig up. It's a CMS, the Centers for Medicare and Medicaid Services. Their website is a gorgeous website, and I say that about very few websites, especially ones that need to be as specific as they need to be with a topic as difficult and interwoven and complex as Medicaid. They do a really great website. They really do, guys. So CMS has a gorgeous website, and you may just want to, and I would recommend it, go on there and look at it, play with it, look at their topics, click on their topics. They are really good with resources and explanations, especially about EPSDT and how it works. There's some wonderful federal resources on these topics. And yes, I can give you those links. But I'm also going to tell you, here's the down and dirty. If you've requested a service and it's been denied, you're going to have to fight for it either way. So even if you go to their state plan and go, look, they're denying it, and I see it listed in the state plan. Well, that's a strong argument. You go to them and say provide it, but you're still going to need to do a fair hearing. You're going to need to protest the fact that it was denied and say to them, hey, no, right? Anytime there's a denial of a service or a reduction of services, you have the right to say no. On the back of that notice will be how to go about requesting a fair hearing, the state to have to investigate this denial. So even if it's on the list and they're denying it, you're going to need to do that. And if it's not listed, then EPSDT can come to the rescue, and I can walk you through how to get a medical necessity determination for the child and look to come equipped, armed with that information, back to the state and say, I want this to be determined a medical necessity and to overturn the denial and get the service to this child, especially if that child has been receiving that service in another state and we've interrupted, right? The continuity of therapeutic benefits to a child is traumatic, absolutely traumatic, right? And the move was difficult to begin with, and we want a continuation of services so that this child is strengthened and their special needs are met. So especially if we go across state lines and state A was providing a service and state B isn't, then we're going to want to make sure that that service is received. So yes, I will absolutely give you that link. Okay, and adoption
Hi, Sharon.
Payment.
That's Michelle's question, and she just provided a little extra information. She said the other state said I would need at least $1 in order to receive Medicaid. $1 adoption assistance payment.
I'm reading. Okay, thank you. Yeah, it's not a new question. It's a clarification of her previous question. Okay, Michelle, I'm in tears. I'm in figurative tears. They're wrong. They're wrong. They're wrong. They're denying a child, and I've got a PowerPoint slide ready and willing and available in a Medicaid training that addresses this exact point. There's a federal law that couldn't get more clear that says for a child in adoption assistance, a maintenance payment is not necessary. For a child in foster care, a payment is necessary. So they're accurate in reference to 4E foster care. They are dead wrong in reference to 4E adoption assistance or any adoption assistance. So, Michelle, send me this. Put together your explanation. Just pull out what you had previously had in your questions. Send it to me in my email, and I will happily have you phone me, email you back, and shoot you the law. It's beautiful, simple, and clear on this very point. So just please know the state is inaccurate, and they cannot deny Medicaid and must provide. You do not need to have a minimum of $1 maintenance payment ever for a child in adoption assistance. Okay.
All right, Sharon, we have one last question that was sent to us in advance. This was a question that I emailed to you that I told you I would bring up during the Q&A session. It's from our friend in Minnesota. She recently had an ICPC case with another state, and they had a great deal of problems because the child was not Title 4E. She had been instructed to tell the family to have the child placed on the pre-adoptive parent insurance immediately. And after the pre-adoptive parent spent a great deal of time applying for MA, they were granted, but then they were ended up getting kicked off because they were already on the parent's insurance. The question is there a better way to handle all of this?
Yeah, what an awful catch-22. Okay. Yes, there is absolutely a better way to handle this, and I've also written a piece with the assistance of the federal government through CMS on this issue. There's two pieces to this issue. One, states cannot require that a family place the child on place the child on private insurance. They can't. If a child is Medicaid eligible, a state cannot require a family to put the child on private insurance. They can't. It's not in Medicaid law. Some states are confused about that because the language of the law says that Medicaid is the provider of last resort, right? We've all heard that expression. Medicaid is the provider of last resort. Well, that phrase means in law that if you have another existing source that is responsible for the provision of health insurance, that has to be tapped in first. That's if you happen to have it, not that you must have it. That's a huge distinction. Does not tell you must have it. It says if you happen to, you got to tap it first and then Medicaid second. And then you do what's called a coordination of benefits, a COB, coordination of benefits between the two providers to make sure that the fullest use of both is applied toward the recipient, okay? However, families have the right not to use private insurance. They may well feel that the child is better served solely through Medicaid, okay? And they have the right to have the child only on Medicaid. They're Medicaid eligible. They're entitled to receive Medicaid, number one. And if the child is a state-funded adoption assistance eligible child going into another state, I would need to know specifically the state in which the child was entering from Minnesota. So this is a Minnesota question. So the child left Minnesota and went somewhere else. I'd need to know what that state was so that I would know what their policies were. And if it's not one of the 4 states, Hawaii, Illinois, New Mexico, Nevada, that across the board flat out deny, then I have lots of latitude to work to get that Medicaid opened, and I've done it. And I've had where states have said that they have to have private insurance, and I have fought that with CMS, and they've agreed with me, and I've laid out the legal argument, and I've written the citations and written a piece on it that lays out the legal argument and says families are not required. CMS says you're absolutely right. You're absolutely right. So if the family wishes solely Medicaid, the child remains eligible. If it's one of those 4 states, then the eligibility component is not going to be through the title and the non-Title IV adoption assistance. That's not going to be your door, remember, to get into the House of Medicaid. To get into the House of Medicaid in those 4 states, you got to go through a window, okay? It's not going to be that door of adoption assistance, which is easier to get through. Got to work on a window, and I'll help you do that. But if it's not one of those 4 states, then it's more than likely that that state should be providing. And then you get to the next argument. And also, they can't require you to put the child on private insurance. And I've got a legal written piece that is concurred with the federal government through CMS that says so. So hopefully those several pieces that I've just mentioned get you to the answer that you would like. And if Minnesota needs to and would like to, please email me if I am not sufficiently answering your question, or if I have sufficiently answered it and you still need my help to intervene and mediate with the state, I'm happy to do that also. Because I have, through the years and in track record, more often than not, gotten to yes. And it didn't all happen overnight. I'm not going to lie to you. I've had to work sometimes, oh my goodness, I've straightened out a state sometimes it's taken a year, literally. And then they've, proactively gone back and provided Medicaid and opened the case. And I've had to work with the assistance state to continue to provide medical assistance to the family while we work it out with the state that's just wrong. But in the end, we have corrected state processes, state practices, and had states change their laws and policies to reflect federal law and the rights that the family have in choosing how their child is best served. Because that's what our parents do, right? That's what all of us as parents do. You do what's best for your child. That's why under child welfare law, in the best interest of the child is the legal guideline. That is the legal bar that we all need to meet, in the best interest of the child. And if that private insurance is not in the best interest of the child, then it is that parent's right to choose to have Medicaid, and if they choose to have Medicaid only, that is their right, because there is no federal law that mandates that families must put the child on their own private insurance. It's just not there. That's a misunderstanding of the law and usually of the phrase provider of last resort, insurer of last resort. That's a different legal term. It's a term of art that states have misunderstood in some states in some instances. So we can do it. We can work together, and I'm happy for anyone to, as I said, send me an email, clarify your question. Tell me where you are in your process and your questions, though, everyone. Tell me, I've already done this, Sharon. I called. I spoke to so-and-so. Here's the contact name. This is where we are along this path. This is where we've gotten stuck. Tell me if you've not even started. Tell me if you're halfway through. Tell me where you are in this, and I will jump in at that point, familiarize myself, talk with you, and see whether or not I can inform you how to work with them. Because sometimes that's the best way, you guys. Sometimes people feel more resentful or pushback if there are more people on that phone call. So I'm all for working it out state to state whenever possible. But if it totally breaks down, and I've already worked with you behind the scenes and given you all that I could, armed you with the law, explained everything, given you the resources, and let you go on to work with them directly, and it still doesn't work, I'm more than happy to go into it. And I'm happy to go into it at any point that you all would wish. I'm just here to tell you that sometimes it's not the best thing to do for me to come in at the front end, because people get some pushback. They might feel a bit resentful. And I'm all about establishing interstate relationships, right? That's why we're here together with ICAMA, to pick up that phone and to have these interstate relationships created and established. And it's nice because a lot of us have been in the field for a lot of years, right? We're a nice group of people, and we stay in this field because we're committed to these fields and these children. And so a lot of times you're dealing with the same people year after year. So let's do it where we are the most amenable and the most pleasant, and we work together and we say, hey, we disagree, and here's why, and here's the law. Can we talk about this, and can we get to point B and the child be served? And again, I'm willing to come in at any point along your process, and if that process stalls entirely, then I will go offline, work with CMS, and look to come back to you and work it through.
Thank you, Sharon. I especially want to thank everyone for joining us today. This has been a wonderful crowd. I'm so pleased with how engaged everyone has been. The comments and questions that we have received have been wonderful. Sharon, you have done a fabulous job of sharing information and sharing it in a way that was easy to understand. Thank you for being with us today and doing that. I would ask that everyone please go ahead.
Oh, I just wanted to thank everyone myself. Everyone, thank you, thank you. There's that old phrase that we learn first on our own, and then teaching is learning twice, right? I learn all over again. So when I teach these and when I walk through these, I learn too. So thank you for your time. Thank you for your participation. Thank you for your questions, because I learn all over again too. And thank you for what you do. I applaud everyone on this call. Thank you for what you do.
All right. So the survey questions will pop up when in just a moment, actually, when we finish. Thank you, everyone. Have a great afternoon, and look for the archived recording so that you will have access to that for yourself and colleagues for future use. Thanks again, Sharon, and bye-bye, everyone.
Bye, everyone.